Okay, welcome everyone to another session with Virtual Spine. I'm honored to host my dear friend, Dr. Andrew Grossbach. He's an assistant clinical professor and also associate program director, expert in complex spine and deformity surgery at The Ohio State University Department of Neurosurgery. So without further ado, I welcome my colleague and friend, Dr. Grossbach, who's going to speak to us about complications of complex spinal reconstruction, avoidance, and management.
Awesome. Thank you, Nader. Thanks for having me. This is awesome that you got this set up and great idea and good way to keep learning in these tough COVID times. So as Nader said, I'm Andy Grossbach at Ohio State. I've been here for about 4 years now, and today I'll be talking about complications of complex spinal reconstruction. A little bit of a different spin than I know there's been some other complication talks and spinal alignment, stuff like that. So we'll touch on that, but kind of touch on some other stuff too. And please, if questions come up during questions or comments, please feel free to jump in. Here's my disclosures.
Andy, I think we're seeing the next slide. Is there a way that you can just show us the current slide? Let's take a peek here.
I would imagine. Let me try again here.
Mm-hmm.
Still going or same?
What do you think, Ali? Are we seeing the next slide or?
It's still the speaker view.
Yeah, I think this is fine, but Andrew, what you can do is just go to display settings at the top.
Oh, yeah, here we go.
Yeah, and just
there you go.
Switch
that look better?
Exactly.
Perfect.
Beautiful.
Thank you.
Awesome. Thanks. All right. So complex spinal reconstruction. It's becoming more common. This is anything from degenerative or de novo adult deformity, adult idiopathic scoliosis, and if your practice is anything like mine, a lot of iatrogenic deformity. So that's flat back syndrome, proximal junctional issues, adjacent level disease, rod fractures, pseudoarthrosis, all that good stuff. So one recent study out of the ISSG reported a rate of complications for adult spinal deformity surgery at approximately 70%, which is quite high. I essentially counsel these patients that you're undergoing a complex reconstruction. You're going to have some complication. Hopefully it's minor, but these are high risk surgeries. So we need to do everything we can to try to minimize these complications. The rates do vary widely in the literature. I quoted that 70% number, but it kind of depends on what you count as a complication. And the retrospective reviews we know kind of undercount a lot of complications. So prospective papers are better and typically report higher levels of complications, just because the retrospective stuff just tends to miss more. Prevention, of course, is the ultimate goal, but recognition and treatment are very, very important. Why is it important? Well, complications can have a lot of negative impacts. So patient outcomes, patient satisfaction goes down, length of recovery goes up, length of stay goes up. Of course, the costs, these are very, very costly to have patients coming back, revision surgeries, and also can have medical legal implications. Kind of divide these into two categories here. Of course, there's the surgical complications. So these are, we think of what we're doing in the OR and complications surrounding that and the instrumentation. So adjacent level disease and PJK, PJF, duodenum or CSF leaks, neurologic injuries, deterioration that can be from malpositioned hardware or issues with decompression, closing osteotomies, vascular injuries, vertebral artery injuries, aortic injuries, or pseudoarthrosis or other instrumentation complications such as rod fractures, screw pullout, things like that. There's also medical complications, so thromboembolic events, DVTs and PEs, pulmonary issues, atelectasis, pneumonia, cardiac issues, renal, GI complications, stress ulcers, ileus, or things like delirium or the ever dreaded vision loss after large spinal fusion. So the first question to answer is, should you offer this patient surgery? I think Dr. Schaffer gave a good talk here recently on your platform here, when to say no to major spine surgery. So saying no is important to know when to do. That relies on, patient comorbidities, their age, their frailty. Are they going to tolerate this surgery that you're proposing? Once you decide to offer a patient surgery, preoperative planning is extremely important. So what correction are you trying to get? What are your goals you're trying to accomplish during surgery? How are you going to do that? That can set you up for success or for failure. And then the surgical techniques, are you able to do what you plan to do? How are you going to do that so you can have a successful outcome? I kind of divide these risk factors into modifiable and non-modifiable risk factors. So modifiable risk factors, things like smoking status. You can have that patient stop smoking. Easier said than done sometimes, but if they're motivated enough for surgery, a lot of times you can get them to stop smoking. There's some that are optimizable, but not necessarily modifiable. So I can't make a patient not diabetic anymore, but I can get them to lower their A1C before going in for surgery. There's non-modifiable risk factors. So a patient has coronary artery disease and stents, you can't go turn back time and unstent that patient. But you have to do what you can to kind of optimize that whether it's with aspirin or beta blockade or something like that. I somewhat jokingly put obesity on here as a non-modifiable risk factor. People can lose weight. It's very difficult. It's very difficult in these patient population. Their back hurts. They're not able to exercise. It's extremely difficult. I can count on like 2 fingers the patients in the past several years that I've had drop significant weight for surgery. And we'll talk a little more about this in a second. And then there's intraoperative techniques that you can change. So are you going to do something different during surgery to help, reduce the chance of complications? Are you going to use intraoperative antibiotics like vancomycin powder to reduce infections? Are you going to use multi-rod constructs to reduce rod fracture rates? Those are all things you can do intraoperatively to help limit your complications. I'm going to quote a mentor of mine.
Hey, sorry to interrupt, Ali Bash. Apologies, I've been known to interrupt speakers often, but I want to ask you a question on your previous slide.
Yeah.
As far as the diabetes and A1C, I apologize if you're going to talk about that later, but I just want to ask you this before I forget, because I think this is an important point. I want to put you on the spot here. A lot of us, develop our own version of the deformity checklist, right? The deformity patient checklist. 1, 2, 3, 4, 5. Addressing diabetes and A1C is an important consideration. What is your protocol? What's your protocol in the hospital in the sense that if you know you have a diabetic patient that comes in, are you checking the A1C? What do you want that number to be? Is it like DEXA scan where, hey, as long as there's improvement over a 3-month period, you're fine? Is it a trend or an absolute number that you're looking for A1C specifically?
Yeah, so for me, it's more of a trend, and I kind of use a trend. So I don't have a same thing for BMI. I don't have a specific BMI cutoff, but I think if a patient can show that they're trending that in the right direction, then that shows that they're motivated, they're willing to do things, and that they have a better shot of having a good or not suboptimal outcome. So I don't have a specific cutoff for A1C. I'd like them, below 7. I'd like them below 8. But I look at it more of a trend. So we're checking A1Cs, on everyone. We have a pre-op clinic that's great. I send essentially every surgery, patient, especially if they're getting any sort of fusion, to the preoperative, anesthesia clinic. And their job is to not just clear the patient for surgery, but to optimize them. I'm not sending them there to say, oh yeah, they should be fine, go for it. I want them to work to optimize those risk factors. And so if they can show that their A1C's, gone from, 8.9 to 7.8, like great, that's a trend in the right direction. What's your practice? Do you have an A1C cutoff?
Yeah, it's funny. We were just talking with one of my orthopedic spine colleagues about that. you know, we like it under 7, right? We like it under 7. We like it as normal as possible. But the reality is we really don't. We really don't have a cutoff. It's like, you know, do we not? Obviously, if a patient is dangerous, you know, it's dangerous to have the operation. You're not going to offer the operation, right? But a patient who comes in with severe kyphoscoliosis, severe pain, you know, with a A1C of 9, right? What are you going to do? You're going to get that consult. You're going to get that nutrition consult. Talk to the PCP, but I think, you know, I don't know if I have established a cutoff number yet to cancel a case. I don't know about that, and you know, let's see what others think. Mike Selby, you're in Australia. You do a lot of deformity surgery. What do you have a cutoff in which you say, hey, I'm not operating on you above a certain A1C, or are you looking for a trend?
So, I mean, the thing about a lot of these deformities is they're not really urgent. So you've got a bit of time. You know, very few of them come in with major neurological deficit. And you know, I've gone as far, and I think we may have touched on this in previous meetings, but in Australia, with our public and private systems, we can admit people, at least in the public hospitals, in advance and actually work them up. So we can bring people into hospital for a couple of weeks for prehabilitation, workup, physician assessment for the really, really high risk ones. But even in the private setting, I've got a team of physicians that basically do all this work for me, which is wonderful because I'm really good at spinal alignment, screws, cages, but you know, I'm not a good physician anymore. And so I'm really relying on my team to do that for me. But I don't have an absolute cutoff for that. I think diabetes and risk factor for infection is really important. The other thing I find in that isn't on that is dental in blokes. So we've had a couple of late periprosthetic infections in blokes earlier in my career, and sort of, you know, the male with bad dentition, and we get that sorted out now as well beforehand. I think that's really important.
Yeah, that's a great point. And you know, I can tell you, Andrew, I don't want to take too much of your talk, but these are really important points. I can tell you what sadly happens often, which, you know, you get a patient, you know, they're diabetic, okay, but they go through the checklist, they end up making it to surgery, and then on the morning of, in pre-op, the nurse gets you know, blood sugar, and it's like 450, and the case is canceled. And then the patient is sent back for the whole workup. So I can tell you that probably that's when cases are canceled the morning of, for better or for worse.
That was yesterday for me.
Oh, okay, there you go. All right, thanks for answering, for addressing that.
Yeah, absolutely. No, that's a great question. Yeah, so to quote my one of my mentors from training, Dr. Howard, University of Iowa, obesity, it's an arms race. You know, we come up with, you know, new techniques, new you know, procedures, new technology, but BMIs keep going up, and you know, you know, if we get too strict on BMI cutoffs, like I mentioned on the last slide, you know, I also don't have a specific BMI cutoff. If they can trend it in the right direction, it shows that they're motivated, that they're willing to exercise, that they're going to be willing to, you know, rehab post-operatively. I think that they show better outcomes. And so, you know, if I had too strict of a BMI cutoff, I work in Ohio, I'd be out of a job. So we looked at, this is our data, it's unpublished, it's preliminary right now, but basically these are adult deformity patients that were operated on the past several years. And we split them into two groups, BMI less than 30, BMI greater than 30. So 93 in our less than 30 group, 86 in our greater than 30 group. As the number of revision surgeries is similar, fixation iliac versus S2AI is similar, 3-column osteotomies similar, the number of SPOs or posterior column osteotomies similar. And we can look at our complication profile here. So interestingly, a few things. So in the greater than 30 group, increased risk of cardiovascular complications, significantly higher risk of DVTs compared to our less than 30 group. Gastrointestinal renal complications, about the same. Pulmonary, about the same. Neurologic complications, same. But the thing that we saw a significant increase in was hardware complications. So looking at screw loosening, iliac screw loosening, and rod fractures in particular. And so it's not surprising, greater stress on those rods are going to have an increased risk of rod fracture. And then looking at reoperation rates, significantly higher for the BMI greater than 30 group. Also, interestingly, we looked at our outcomes data in these patients. Didn't have as good of follow-ups. There's less patients in each group as far as filling out all these forms. But these patients do get better. Looking at ODI, VAS, leg and back, SF36, patients got better in both groups. So we counsel these patients. They can improve after these large surgeries, but they're going to have a higher complication rate. What are you doing to optimize these patients, these modifiable risk factors? So, patient comes in with cardiac risk factors. Typically they're getting stress tests, typically beta blockade around the time of surgery. I leave all these patients on a baby aspirin, pretty much regardless of what surgery I'm doing. I think the bleeding rates is low with a baby aspirin. I think the benefits outweigh the risk. Pulmonary, I typically make patients stop smoking for 8 weeks. There's studies that show that improves outcomes. COPD, obviously, you want to kind of optimize them. You don't want to be doing these when they're in a COPD exacerbation, anything like that. Osteoporosis is a big one. Calcium supplementation, vitamin D supplementation. There's some studies that show that it's really not cost effective to check a vitamin D in everybody. Supplementation is pretty cheap, pretty safe, and so maybe all these people should just be on it. And then parathyroid hormone, Forteo. I have a lot of patients with osteoporosis that I'm getting on Forteo before we ever venture in and try and do a corrective surgery. And as we touched on before, diabetes with A1C. And on the opposite end of the spectrum, patients that are malnourished, checking albumin, pre-albumin, getting them on some supplementation before surgery, improve their healing rates. I won't belabor these points too much. Everyone's pretty aware of these spinal pelvic parameters, but these are things that you really need to be good at, and this is going to help you with your preoperative plan to make sure you're not undercorrecting, overcorrecting people, to cut down on proximal junctional issues, rod fractures, everything like that. Coronal balance, of course, CSBL, pelvic obliquity. Do they have pelvic obliquity that's going to throw things off and affect your construct?
Andrew, we had a question from one of the participants, Dr. Imid Hariri from California, about the osteoporosis. Getting back to again what your protocol is. Again, sorry, these are sometimes difficult questions, but do you have a cutoff before you say, hey, you know what, it's -2.5, it's osteoporosis, I'm going to send you to an endocrinologist? Or do you start Forteo or a similar type of medication? Can you just go into detail about that?
Yeah, absolutely. Good question. I'll touch on it a little bit here in one of these cases too. Essentially, anyone that is T-score less than 2.5, -2.5, they're all going to a bone endocrinologist. I used to try and manage the Forteo myself, but it's just getting it approved. It's expensive. You got to fill out all these forms. There's help financially to get it paid for, and the people that do it all the time, they're just so much better at it. There's the labs they need to check and follow. It's just easier to have somebody that does that every day, rather than trying to do it yourself. So I have a bone endocrinologist that I send a lot of patients to, or if they're in the osteopenia range, but they've had some other, they've either haloed screws, they've had proximal junctional issues, or something else that makes me think that they're not gonna heal as well. So definitely, if they're full-blown osteoporosis range or osteopenia, and they've had some other issue. And of course, I take into consideration too, am I doing couple level fusion, or am I doing like a big scoli case where I'm really having to crank on a rotational deformity? How much am I going to need to be pulling on those screws? That's also something I take into consideration. Yeah, so talking about alignment, gap scores is somewhat newer system that kind of expands on some of these spinal pelvic parameters. So looking at relative pelvic version, what their measured versus ideal sacral slope is, relative lumbar lordosis, so similar to PIL, mismatch on where you want that. Lumbar lordosis distribution index, definitely something to keep in mind. You want a lot of your lordosis, typically at least 60%, between L4 and S1. So if you have a patient with a flat back, you'll probably want to do a PSO at L2. It's very non-physiologic. They're going to have increased risk of running into problems. And then relative spinal pelvic alignment, it's kind of looking at a global spinal alignments like SVA plus pelvic tilt. All right, so let's get into some cases. First patient here, 72-year-old female. She has a many-year-long history of back pain, been progressively getting worse, difficulty standing for prolonged periods of time. She does have radiculopathy kind of both sides. Not really able to tell a specific dermatome, but definitely pain going down the back of her legs. She's failed all the conservative modalities, physical therapy, water-based physical therapy, epidurals, radiofrequency ablations, various pain medications. She's got a history of hypertension, type 2 diabetic, hyperlipidemia. And she looks like this. So again, it's not a measurement talk, but just kind of eyeballing these, coronally, she's pretty off. Her CSBL is off to the left. She's got this big thoracolumbar curve. Shoulders are pretty balanced. Sagittally, she doesn't look horrible. Her C7 plumb line SVA is a little anterior, but not too bad sagittally. And then her frame and all look pretty bad in the concavity of this big curve, and then in the concavity of her fractional curve. So thinking about risk factors, what are these risk factors are we concerned about? I'm concerned about all of them, of course. She's got hyperlipidemia, she's got hypertension, she's got type 2 diabetic. So she definitely has, cardiac risk factors. So she's going to need to work up probably an EKG and a stress test that our pre-op clinic's going to do. Nutrition, we need to make sure she's getting adequate nutrition. This is obviously not going to be a small surgery. Thromboembolic, I'm always concerned about all these patients. I typically do use IVC filters for the patients I'm, particularly worried about. I was going to ask the panel here, how many of you use, IVC filters for these type of deformity cases? I know there's not a ton of data.
I don't know what others think, but I don't use it prophylactically.
Yeah, I mean, it depends. If there's a history of a VTE, the threshold is lower. Typically here, if you're doing a stage operation, let's say you want to do a 2-level A lift, then a T4 to the pelvis, then yeah, they'll put the filter and they'll do the exposure. That's the first stage, and then the second stage. But it's typically for stage operations here at Northwestern, especially if you're going to go from the front, and manipulate the vessels and what have you, and then implant stage 2. So they'll do it during stage 1 before they do the exposure to the anterior spine.
Yeah, just curious. Wound healing issues, bone quality issues, as we talked about. Psychosocial issues. So does this patient have the support that they're going to need when they're healing this large surgery? So here's her DEXA scan. So she's in the osteoporosis range. So this is something that definitely gonna want to treat beforehand. So as I mentioned, bone endocrinology is a great teammate to have on your care team. That's going to help you deal with this before surgery. So they need vitamin D and calcium optimization. Like I said, there's some studies that show that it might not be worth testing. Just supplementation is pretty cheap and pretty cost effective and low risk. So probably getting them on supplementation is a good idea. And then a lot of these patients are getting on Forteo. There's good data that shows that improves fusion rates, decreases screw loosening in postmenopausal women undergoing spinal fusion surgery. At 72, she's clearly postmenopausal. I typically treat with Forteo for at least 2 months preoperatively, and then up to 2 years total, as it's approved for use up to 2 years in the U.S. So here's what we did. This is T4 to pelvis, and she was on Forteo for several months beforehand, and ultimately did well. Next case here, iatrogenic sagittal deformity. So this is something that probably a lot of us see fairly commonly. Patient comes in, 58-year-old female. She's had several years of back pain, difficulty standing upright. She's had a lot of lumbar surgery before. It starts with, laminectomy, then maybe another laminectomy. Then she got a fusion. Then, they extended the fusion. Then they went back and extended it again. So she's not, she's like, I don't know. They just, went in there and kept, doing things. And I kept getting maybe a little better, then a little worse. And by the time she comes to see it, that she's got, several levels fused. She's of course failed all the conservative modalities, type 2 diabetic again. She's one of those ones, usually make them stop. Wanted to include it in this. There's a couple of people that get down to like 1 or 2 cigarettes. They're getting worse. So sometimes I'm a softie and I bend the rules a little bit. But this is what she looks like. So she's fused L1 to S1. You can see stages here and some connectors. And she's fused at these levels. She's got, posterior lateral fusion. She's got some interbody fusion. So these levels fused. And so again, without belaboring the alignment too much, you can just tell by looking at her, she's fused flat. She's got, her SVA is high. She's got some adjacent level stuff going on. They stopped at the junction. So she's got, vacuum disc and scoliosis above it. She's, flattening her thoracic spine out, trying to compensate for this flat back deformity. And this is someone that, you're not like, unlike the last patient where we got away with, multiple SPOs, posterior column osteotomies across that curve. She's fused. So you're not going to get away with posterior column osteotomy. So she's going to need 3 column osteotomy if you're going to add, if you're going to get her back into alignment. The other thing I always, think about, where are we stopping proximally? So she's fused up to L1, plan to L4, pedicle subtraction osteotomy. As we talked about the lumbar distribution index, we want that osteotomy low. I don't want to be doing this at L2 and really tipping her back, higher up. I include a couple of axial cuts here. These are the proximal 2 levels. So she's got some stenosis, some, kind of lateral disc there around the cord. I'm going to want to decompress those levels. And I don't like doing a posterior decompression and stopping at like T10 if I'm taking like T11 lamina off. I want that posterior tension band. So I decided to take her up a little further to T4. So I've already T4 to pelvis, L4 pedicle subtraction osteotomy. Again, risk factors I'm concerned about. All of the below. Obviously cardiac. She is a smoker. She's down to like a cigarette or 2 per day. Been seeing her back in clinic, really trying to get that last cigarette gone, but having trouble doing it. Pulmonary, of course, in a smoker, former smoker. Nutrition, she's pretty robust, so no, not too much worries there. A1C wasn't too bad. Again, thromboembolic. Wound healing is a big one for her. So smoker, former smoker, multiple lumbar surgeries. You're going through this incision again. 3 column osteotomy. Blood loss is going to be high. Probably going to get transfusions. Increased transfusions. Increased wound healing issues. Increased surgical site infection. Bone quality. Of course, she's getting a DEXA scan. And the psychosocial factors. So this is what we did for. This is L4 pedicle subtraction osteotomy. See the IVC filter hanging out in there. So those are immediate post-ops. This is relatively recently. When I do a 3 column osteotomy, I want extra rods across that. So she has 5 rods across this PSO site. So she's got 2 satellite rods you can kind of see down at the 1 level above, 1 level below this. Use those to close the osteotomy. She's getting her main rods, and then she's getting a satellite rod or an accessory rod, excuse me, across that. So want to give her kind of maximum opportunity to heal that 3 column osteotomy because it's going to be an issue for her. Other things.
That's a really, really nice result. Congratulations. Can you show the pre-op real quick? I have a technical question for you as well as for some of the faculty with us. What is your opinion on cases in which, obviously here you need to go down to the pelvis. What is your opinion on cases in which there is a solid arthrodesis, let's say, below, and you're extending the construct? You don't need to do a PSO or deformity correction. What are your thoughts on that? Do you refuse and re-instrument those, or do you just extend and leave those segments without instrumentation? I know not necessarily about this case, but just in general, I kind of go back and forth with some colleagues on that. I never think that bone and that fusion is strong enough without instrumentation, and I've seen it fracture. So even though sometimes I take out hardware because it's fused and I extend, I re-instrument those levels and I feel it's more robust. I'm wondering what you, Nader, Alex, and others think about that. I've just seen a couple of cases in which, you know, patients came back with delayed fractures across a fused segment.
Yep.
And Wendy, also from a neuroradiology perspective, I'd love your opinion. You know, when you see a fusion on CT, is it as good as bone? Is it as solid as regular bone? I just don't feel like it is. It doesn't matter how fused it is. I don't know. What does everybody think? I know it's maybe an unanswerable question.
It's a great question. My answer is 90% of the time I do what you do, and I don't rely on a posterior lateral fusion mass to be as strong as regular bone. So I typically you know, swapping out instrumentation and not just taking out and extending. I have a couple of select cases where, you know, they're older, they just have just an adjacent level thing, where I might try to just minimize surgery, minimize the amount of stuff I'm doing. But vast majority of the time, I don't like to rely on an old posterior lateral fusion mass to support. What does everyone else think?
Yeah, Andrew and Ali, I'm with Ali on this. I think the risk of fracture through that long segment, it's almost like an ankylosing spondylitis situation, right? You know, you've got this solid mass of bone, but the outside of it's really hard and the inside's often not great quality. So I often go back into the fusion mass, and if I upsize screws there, I may not go the same density, but I cement them in as well. So I use cemented screws in the fusion mass, and it can be quite helpful.
Has anybody actually measured like Hounsfield units or any other objective parameter of the fused bone? I mean, I feel like I should know this, but I really don't. You know, a more objective analysis of what the strength of that bone. Is anybody aware of any studies assessing that fusion mass?
Yeah, I'm not aware of a study looking at the post-lateral fusion Hounsfield units on a CT scan. That'll be interesting. That'll be interesting. You know, we usually measure, you know, like the the vertebral body itself. If it's less than 80, it's discouraging. 100 borderline, more than 100 is okay. But the fusion mass, I'm not aware of it. And I agree. I mean, you got to swap the hardware, especially in long constructs. If it's just you have an L45 and then you're extending to L3, no problem. You can remove the L45 screws and just, you know, and then upsize the 4 and add 3. But for long segment constructs, sometimes you see a fusion at L5S1 and then you put iliac screws to offload those S1 screws, although it's a fused segment.
Wendy, what were your thoughts? I thought you were going to say something, Dr.
Yeah,
Gross.
I was just going to say, I mean, kind of what I said in the chat, that the Hounsfield units aren't always the most accurate way to go because, you know, the photon attenuation depends on how much soft tissue it's going through. So it'll depend on the patient's body habitus. We have our general guidelines, but it's not exact. But I also have not seen any studies on that. I would have agreed with everything that was said, that it would be weaker, but I don't know that you can tell on the CT.
Interesting question.
Andrew, can I just ask you a technical question about a L4 PSO?
Absolutely.
Yeah, look, I do them every now and again, but is there anything that in the vascular anatomy at the front that makes you concerned about doing it? Do you look at that before you do it, or have you found that it's not a huge issue? I mean, fortunately, I've never seen a rising pool of blood there, but I know I'm carrying tools very close to often a iliac or big iliolumbar that's crossing over that region.
Yeah, that's a great question. I mean, I typically, you know, no matter what level I'm doing a 3-column osteotomy on, I'm typically looking at where that vasculature is. But I'm concerned whether it's IVC higher up or whether it's iliacs lower down. I fortunately, knock on wood, haven't run into an issue. But I think it's worth at least noting on the MRI where things are and you know, just being extra careful. always something. Anytime you get into the anterior portion of the spine, you got to be, aware of where those vessels are. But yeah, I mean, I think the reason that people kind of, we're doing these 3-column osteotomies higher up before we kind of, figured out how much the lumbar distribution index matters, is because, a lot of times L4 is deeper, it's tougher to get to, and so you got to take a little more time and make sure that you can see where you're going and that you're, being safe.
Yeah, and I mean, to me, the vessels also divide across there, right? So sometimes you've got more to avoid at the front in terms of just being worried about where everything is.
Absolutely. Yeah. So of course for her, like I mentioned before, I'm concerned about wound healing issues for her. She's had multiple lumbar surgeries. We're going through it again, multiple levels. There's a recent study that shows that patients with 3-column osteotomies have, about a 5% surgical site infection rate. So they get infected more often. Risk factors are in her, obesity, smoking status, diabetic, posterior fusions in general, and definitely when you're going through the same incision multiple times. Perioperative blood transfusions, if you're doing a 3-column osteotomy, they're likely going to get OR time greater than 4 hours. These are all risk factors for problems with wound healing, surgical site infections. There are some things we can do to combat that. Use of intraoperative vancomycin, has some good literature out there. Use of antibiotic or betadine irrigation has also been shown to reduce surgical site infections. So I use both of these in my cases. Something else I've been using recently over the past year and a half or so is negative pressure wound therapy. So there's pretty good literature in the orthopedic trauma, cardiothoracic, plastic surgery literature, not a ton in spine. But I'll show an example of this device here in a second. And readmission for surgical site infections is very costly. $13,000 for a readmission. Some papers show much higher than that. So this is this negative pressure wound therapy device. So basically, it's you close and close with whatever you're comfortable with, and this sponge goes over the top of that and basically applies some negative pressure. The idea is helps reduce fluid collection, seromas from forming there. Pulls blood and kind of jumpstarts that healing process. So I'll typically leave these for 7 days or so after. They just peel right off. Patient can do it at home. They bring the little device, the box, back to you in clinic next time they come see you, and they recycle that. And I think they've been working well. This is some of our data. This is a retrospective series we did. It's retrospective. It's a little skewed. I had like 2 patients come back like within like a week that had wound issues, and I got upset and said I need to do something else to help remedy this. So kind of threw the numbers off a little bit, but I think it's interesting. So we had 42 in our control group and 42 in our Provena negative wound pressure group. Surgical site infections, significantly less in the control group. Superficial dehiscence. So these are those patients that are coming back and you're saying, maybe we'll leave the stitches or staples for another week, maybe come back again. Outpatient care are exactly like those patients. We're having to like worry about it. It's not infected, but it doesn't look great. Let's check it again. Or hey, can you send me a picture next week, show me what it looks like? Or maybe go see our wound care clinic. They'll put some fancy dressings on it. It takes people's time, takes people's energy. Patients aren't happy they have to come back for more visits and stuff. They're worried about it. So yeah, we definitely saw a decrease. And just subjectively, the wounds look nice. They come back for their staple remover or whatever. They just look healthy, look nice. Perioperative blood loss, of course, we're talking about increased number of levels of fused. Blood loss goes up. Obviously, a T3 or T4 to pelvis is a lot of levels. 3-column osteotomies, patient got a PSO. Blood loss goes up. So higher blood loss, more blood transfusions leads to coagulopathy, hemolysis, anaphylaxis, increase in surgical site infections, and delayed wound healing. One thing that's been used, and I think fairly well published on now, this is our data using TXA. So on the left here, you can see the red line is our TXA group and the blue line is our control group. So as the number of levels fused goes up, blood loss goes up, but less significantly in the TXA group. And on the right, our table is showing that this significantly reduced EBL and also significantly reduced number of units of red blood cells and FFP. So how I do it for these.
So Andy, can you go back to the previous slide, please? So these are patients, sagittal deformity. So PSO patients, or what's the case mix there?
Lawn segments. So anyone 7 or more levels. We looked at basically any posterior lumbar fusion we found. As you look to the left of the graph, like 7 levels is kind of where they start to diverge. Less than that, there was no significant difference in blood loss or anything. But we found that once you hit 7 levels or greater of segments fused, then the TXA had a increasing role in decreasing blood loss as the number of fusions went up.
Mm-hmm.
These are basically getting whatever sort of osteotomies. We just basically looked at the number of levels.
So they include some PSOs, and some patients didn't have a PSO, like a 3-column osteotomy. Okay, and then do you use an aquamantis too with these, or just bipolar? Okay,
I do, yeah.
And then you said some of them aspirin. They were on aspirin.
Anyone that comes in with any sort of cardiac thing, they're on a baby aspirin. I let them stay on baby aspirin. If they're on a 325, I switch it to a baby. If they're on Plavix, I hold that, of course. If they're on anticoagulation, I hold that, of course. But a baby aspirin, just I don't have data that shows one way or the other, but just subjectively, I don't think it makes a whole lot of difference.
Got it. Okay.
So how I do it, so these patients, basically anyone who's getting any deformity correction, any sort of osteotomies, definitely 3-column, but even posterior column, they're getting TXA bolus 30 milligrams per kilogram, and then running at 3 milligrams per kilogram per hour during the case. As soon as we close, then they can stop it. Pack posterior lateral gutters at the levels I'm not working on. So you instrument, you're going to do your osteotomies, unpacking the posterior lateral gutters while I'm doing my osteotomy cuts. I'll always use antibiotic irrigation. We use 3 liters of irrigation. We get this 3-liter bag. We know it's the same amount of irrigation every time. We wash it out with 3 liters. Antibiotics are in the irrigation. I'll typically use 2 grams of vancomycin powder in the incision near the bone graft and kind of sprinkle it in the various layers during closure. And these patients are getting a negative wound pressure therapy for 7 days. All right, next case. So this is a gentleman who already is having some complications, and we need to figure out what to do to kind of get him back on the road to recovery. So he's a 55-year-old smoker, malnourished. This all started at an outside hospital where he underwent a 2-level anterior corpectomy, cervical corpectomy in 2017. Had some graft subsidence, something like that. Extended it back multiple times, anterior, posterior, combined, several surgeries. He's kind of lost track of how many he had. Unfortunately, the last go at it got infection both anterior and posterior. And so he was transferred to us in a halo vest. Luckily doing well neurologically, a little numbness, very deconditioned. And this is what he looked like when he showed up. So on the left, you can see his x-rays. They've removed the anterior instrumentation. You can see some things that are trying to be vertebral bodies. Posterior instrumentation's pulling out. He's kyphosing over. And this is what a CT scan looks like. So when he lays down, things kind of line up again. You can see some leftover bone graft material here. Still see some staples in place in the back, and a lot of air here, of course. So we had him in the halo vest. There's some kind of nasty looking fluid kind of leaking out from underneath it. So we got to go to the OR and put him in Mayfield and look at what's going on underneath this. So this is what things look like underneath the halo. So he's obviously infected, wounds falling apart. Luckily neurologically he's doing okay. Here's his MRI. Doesn't look too horrible as far as the spinal cord. There's some other things that look not great. So what are we going to do with this guy? So he's going to need, obviously this cleared up before he can revise his instrumentation. So this is one that it pays to have a good plastic surgery team where they're going to be able to come in and help you get this cleaned up prior to surgery. So we took him first for a washout debridement in conjunction with plastic surgery. And I really like these irrigating wound vacs. They introduced me to them, and I've used it to salvage instrumentation before. Basically, it's a wound vac that goes on an open wound and then continuously irrigates. And so had the irrigating wound vac, would go back to the OR every week or so, kind of check, tissues getting healthier. Once it's appearing, more healthy, then we do our definitive, surgery and combined closure. So we revise them posteriorly and had plastic surgery turn a trapezius muscle flap, and again place that negative wound pressure device that goes over a closed wound to get that to heal. I know you're probably thinking, and I was thinking at the time, there's no way this is going to heal without anterior column support. But if you go back and look, this isn't a typo. He had a C4 to T1 corpectomy in the front. So a lot of levels. Been through multiple times. I'm anxious about going back in front because I'm like, this guy's swallowing right now. If we go back and try and do any more, I'm really worried about his spine. It's gonna be all scarred in there. There's burnt out infection. So we revise him posteriorly, and this is him about a year out. And so, he did okay. The corpectomy, they're drilling out the center of the vertebral body. He still has non-cement processes. It's infection. You get the infection treated, they typically fuse. So you can see he fused all the way through here. Very fortunate. I was worried we're gonna have to be back in the front, but he actually did okay. One more here. This is another patient that try to optimize, but you're just never going to get fully optimized. So 49-year-old chronic alcoholic. He's being treated for esophageal varices at a local hospital here. Had a fall while at the hospital. So they got a CT. He was found to have a spine fracture. He has liver cirrhosis, pancytopenia, not doing great. So here's his CT at the outside hospital and his MRI. So he has a 3-column injury, bony chance fracture. He also has disruption of his ligamentum flavum, as seen on the sternum image here on the right. Not surprisingly, they didn't think he was a very good surgical candidate, and they tried to get by with a brace. Judging by how he looked, I might have done the same. But we know that these just don't heal well. Don't heal well in the brace. So he was out, 6-8 weeks, and he came back to me.
Can I apologize? You can go through a story, but before you show what you did, can we poll the audience and the participants to see what they would do?
Absolutely.
Awesome. No, go ahead and finish the story. I just want to ask the participants and other faculty what they would do.
Yeah. So he walked around in a brace for a while, and then came to see me in clinic. So he's had more compression anteriorly, and some more kyphosis across that level. And now it's, what do we do with him? He's still cirrhosis, esophageal varices, still drinking, but worsening back pain. He's kyphosing over more. So it's a tough situation.
What do you think, Nader? What would you do?
So, I mean, to me, to operate on a sick patient, I just like to have good hemostasis. I mean, if low ejection fraction, we get them through it. Kidney disease, with okay coagulation, we get them through it. But like if someone can't coagulate, so what's his platelet like? Does he have any platelet dysfunction? I know as alcoholism, liver cirrhosis. How does his platelet work? I mean, can he coagulate? Because if you go in and it bleeds, then that'll be tough. But in terms of surgical management, obviously fixing this is more difficult than fixing it when it's fresh, before he develops kyphosis, because this may require a PSO. I would do a posterior long segment fixation, fusion open, because I'm not intending on operating on this patient again to remove the hardware. So I will do two up, two down above the index level, and do arthrodesis as well up front. Because now it's a difficult situation. Now he has like post-traumatic kyphosis, and the fix for that is a bigger operation than than what would have been upfront.
Nader, if you get a new Andrew, is that an old CT or a new CT on the left?
This is his repeat about say like 3 months after his fracture.
Okay, well that's what I was gonna.
Initial
Okay,
one looked like this.
Nader, I was gonna ask, would it change your opinion if you compare, say, the upright X-ray with a scout or a CT? If he reduces a little bit because the fracture hasn't healed yet, maybe you can get away without answering.
Yeah, correct. Yeah, you may get away with it. Absolutely. I mean, you want to minimize. The CAT scan looks a little bit better than the upright film, so you may not need a big. You may not need a PSO or a corpectomy. You can just do the same. Maybe SPOs, and he can get better reduction. But up front is the easiest. Go to the previous slide. That would have been. That would have been a. So that's why you don't want to miss on these unstable injuries, because fixing them down the line becomes a bigger deal.
Yeah, it looks like most would go posterior with possibly cement. I think we had one vote for corpectomy. What did you do, Andrew?
So did this. Went posterior with cement. So of course I'm worried about his bone quality. In him, and I did open to Nader's point. I'm not planning on going back and taking out this instrumentation. I certainly do plenty of perk screws. For him, I'm worried about. He's 3 months out now. I don't know if that fracture is going to heal great regardless. Some arthodesum. Worried about the bone quality. I don't have months to get him on Forteo. So I'm going to optimize his nutrition as best I can. Hepatology consult, vitamin D, calcium, preoperative platelets. His platelets are fairly low, and then did a 2 up, 2 down with cement augmentation. And it's always about risks and benefits. Am I going to get his kyphosis better by doing a corpectomy? Sure. Is it going to be worth the risk for him, given all his bleeding issues, all his other comorbidities? I don't know. So I decided to as you pointed out, he does correct a little bit when he lies down in the scanner. So I decided to get him as best I could and fix him in place. Post-operatively, he's going to need a lot of help, a lot of support. Comprehensive metabolic panel daily for the first several days. Follow his coagulation factors, his platelets. Pain meds, you got to be careful about ones that are excreted via the liver. So getting pain team on board, getting medicine team on board to help follow with all this, very important. So I think that's all I got.
Thank you very much, Andy. This was fantastic. I mean, it's surgery risk benefit, right? Like you want to minimize the risks and maximize the benefits, and you do that with optimizing every single variable that can be optimized. Bone health is a big one. You know what I mean? I mean, bone health is a big one, and low threshold to sending these patients to a bone specialist and starting with the Forteo, continuing with the Forteo. So how long do you keep these patients on Forteo before you operate on them? If you have time, let's say it's not urgent, you have a deformity case, would you keep them 3 months, 6 months, or is there, what are your thoughts about that?
I think the longer the better. I typically say at least 2 months, but in these, as pointed out, these are typically in the deformity patients. They're not emergencies, so you have time. And so I think the longer the better. I say, if they're on it for at least 2 months, and I usually make them, be on it for 2 months, then come see me in clinic. I can verify you've been taking this for 2 months. Yes. Okay, now we can go ahead and schedule surgery. I schedule, 6 weeks out or so. So then they're on it for, good 3-4 months before we ever cut skin. And then I keep them on it post-operatively. They stay on it for, up to, 2 years if they can. That's what it's approved for in the US. So.
Great. And then now at your institution, is the Prevena now the negative pressure dressing standard of care, or you just do it, just your practice, or
my practice? My partners are slowly adopting. They'll use it for particularly high-risk patients or for You know, people have had wound issues in the past. I've kind of migrated. I first started using them for, you know, you get an obese patient and they get this roll on the upper back between the back and the neck. And so you know, your long segment cervical thoracic fusions, they'd have these little wound healing issues right there. And I had 2 in a row, and that's what prompted me to start on there. And they were coming back to clinic and they looked so good that I'm like, okay, these are going on my deformity patients. And then it's gone to like, okay, any posterior fusion. So I pretty much, if I'm doing a posterior instrumentation, they're getting one. My minimally invasive stuff, I don't. If I'm doing minimally invasive, you know, perk screws, MIS, T-lifts, you know, X lifts, I'm not for them. But any open posterior fusion is typically getting one for me.
Excellent. Any questions from the panelists or the hosts to Dr. Grossbach?
I was just going to say, Andrew, that the cervical case you showed was a great job. I was looking at, I would have probably done occiput on that and wussed out and sort of gone long, but it's a better result for the patient stopping at C2, I think.
Yeah, luckily a lot of those screws left a lot of his anatomy relatively intact posteriorly, so we were able to get, you know, good lateral mass screws in, bicortical lateral mass screws, long C2 screws, really upsize the T1 and T2 screws. You know, sometimes it's not. You know, if their anatomy is all those screws pulled out and you don't have good purchase, then absolutely going up to occiput, extending down into the mid thoracic, 100%. Luckily, his anatomy back there, we were able to get, you know, good purchase at pretty much every level. So it spared him going up to the occiput.
That's great. Okay, beautiful. So Andy, I can't thank you enough for joining us this evening. This will be uploaded on our YouTube channel. So for individuals who could not make it, they can watch it on YouTube because it's very useful. You know, first thing and foremost, do no harm, you know, and that's what we do. You gotta find the right indications and optimize those patients and then proceed. So next week, Dr. Baj, what's in store for next week?
Yeah, we're hosting our very own panelists, our virtual spine panelists, Doctors Galgano, Goodwin, Mamagani, and Dr. Selby, if he changes his vacation plans. No, I'm just kidding, of course. Whoever's, we have some what we call family cases next week, a myriad of tumor degenerative trauma cases from our own panelists of virtual spine, and we're excited about that.
Okay, beautiful. Well, thank you, everybody, and have a great evening, and we'll see you guys next week.
Awesome. Thanks so much.
Thank you.